from the Asia Pacific, and we have a great meeting for the APSC Crowd Forum of the Cardiovascular Disease Series. We are managed the contemporary management of the mechanical complication in acute myocardial infarction, surgical repair versus transcatheter closure. And we have a 2-hour discussion and the presentation. The annotation is emerging coronary transcatheter intervention reduced the significant instance of the post-AMI mechanical complication, including the severe mitral regurgitation from papillary muscle rupture, ventricular septum rupture, and the free wall rupture, or the LV aneurysm formation and the RV infarction. However, the timeline of the mechanical complication happened paradoxically move forward to the first few days during the reperfusion, intramyocardial hemorrhage, etc. Early ignition and the early surgical decision-making become vital to survival of the critical ill patient. In this session, we will discuss in depth the current concept of therapy strategy in the urgent management of the acute myocardial infarction mechanical complication. That is RV infarction, severe mitral regurgitation, free wall rupture, or pseudorenal aneurysm, or ventricular septal rupture, and more complicated LV aneurysm. And I'm the Yih-Sharng Chen from Taiwan. I also like to introduce another very famous cardiology from Thailand. He is the Dr. Kasem. He's the president of the Heart Association of Thailand, and he is the Thai Society, the president of the Thai Society of the Cardiac Image. Okay, let's start the program. Next, please. Let's start. Allow me to introduce the first speaker. He will talk about the measurement of acute myocardial infarction complication with the cardiogenic shock, RV infarction versus LV infarction. Dr. Jehangir Ali, he's an associate professor of cardiology and consultant in interventional cardiology. He's associate director of the CAS lab in National Institute of Cardiovascular Disease in Pakistan. Dr. Ali, please. Show Dr. Ali's slide. Thank you.
So,
Dr. Ali?
Dr. Ali, you can start your presentation.
Start your presentation. Dr. Ali? Jehangir Ali, did you hear me? Show your slide, please. Okay. Now we
hello.
have. Hello?
Hello, can you hear me?
Yes, clearly.
Okay, thank you. Thank you for a wonderful introduction. I am Dr. Jehangir Shah, working here in Nai-Hsin. So, morning from Pakistan. Today's topic given to me is the management of acute myocardial infarction and complicated with cardiogenic shock. Later on, we will discuss the difference between RV infarction and DL. As we know, the myocardial infarction is the leading cause of the death, and its complication, cardiogenic shock, is a life-threatening condition which may lead to the death around 50% of the patient. So I don't have any disclosure or conflict of interest. So the myocardial infarction, myocardial infarction is the leading cause. As we know, the incidence of myocardial infarction is around 3.8% to 9.5% worldwide in different age groups. And it is mostly because of the opening of the coronary arteries may lead to the type 1 MI according to the fourth universal definition. They are the signs and symptoms of ischemia along with ECG changes, and there's a rise in troponin more than 99%. Whenever there is a myocardial infarction, that may lead to the ischemia because of the opening of coronary arteries, may lead to the injury of the myocardium. And that injury may lead to the decreased cardiac output and followed by hypotension. And this hypotension may lead to further decrease in coronary perfusion. This is a vicious cycle. So the revascularization is the treatment option. Stop this vicious cycle and save myocardium from the injury. And cardiogenic shock, the incidence of cardiogenic shock is 5 to 10% in myocardial infarction. The definition of cardiogenic shock, according to the principle of critical care, is the coronary is the circulatory failure due to the pump dysfunction. And in Harrison principle shows that low cardiac output state resulting in life-threatening end organ hypoperfusion and hypoxia. In cardiogenic shock, persistent hypotension that is unresponsive to volume replacement or worsening with volume with elevated of leg death may lead to the hazards. The clinical presentation and physical examination is depend upon the involvement, the RV failure sign, the left heart failure sign, and the shear front. Whenever there's a right ventricular failure, there's a volume overload sign, edema, sacral edema, epitomegaly, raised JVP with dilatation of RV may lead to HER, you can find the 12. Because of the hypotension and hypoperfusion, whole periphery, cyanosis, orthopnea, and delay capillary defect. Left heart failure may lead to the crackles, respiratory bleeding, and space heartbeat and left-sided heart. So this is a very busy slide because when the opening of the epicardial vessels may lead to the myocardial ischemia and cardiomyocyte necrosis. And that necrosis may lead to the decreased left ventricular function, and that may be followed by the systemic hypotension, decreased coronary perfusion pressure. Sympathetic and neurohormonal activation may lead to the increased circulating catecholamine, vasoconstriction, increased systemic respiratory resistance, and the Ross cascade activated and increased salt and water retention by kidney, lead to volume overload. Further, there will be a pulmonary congestion. Decreased cardiac output, hypoperfusion may lead to the end organ damage. As we know, the shock is a multi-organ failure and the involvement of the brain, liver, gastrointestinal tract, kidney, and lungs. So according to the sky shock stage is divided into stage A, B, C, D, and E. And stage A patient having a risk matrix, and stage B the beginning, and C, D, and A they mostly present with the symptoms. So from the early benefit stabilization to salvage, you have to consider the factor that may favor early mechanical circulatory support device. Those patients who have stage C, D, and E, because of the selection of the patient is very important. And those patients who have a persistent hemodynamic electrical arrest by the instability despite initial myas and high coronary anatomy, high risk coronary anatomy, and severe valvular dysfunction, you can consider for mechanical circulatory support. If you see this figure that shows the acute myocardial infarction from 1997 to 2017, the cardiogenic shock overall from 13% it reduced up to the 8%, but cardiogenic shock at admission at around 4 to 5%. And you can see the mortality, the initial mortality was very high because of the unavailability of the new devices and techniques along with inventory. So the mortality decreased from 60-70% up to the 45-50%. So you have to assess the patient and classify the shock. Patient have a stable blood pressure and perfusion pressure, having a category A regarding the sky shock to revascularize the culprit vessel, that is the class 1 indication. And in those patients who have a stage E, they have a morbid patient, limited goal of care, and then most of the patients, they go for the palliative. After stabilization, patient have a low blood pressure with well perfusion, consider the vasopressor inotropic support, increase the pressure for more than 90. And in hypoxia, acidosis, the intubation or ventilation required because the early intubation or ventilation support will decrease this lactic acidosis and hypoxia because they may lead to the ventricular fibrillation and reversal. Diagnosis caused by shock and defined hemodynamics. You have to do the revascularization immediately and a mechanical complication. If you find a mechanical complication, surgical consult is the class 1 indication in these patients. So these are the sky stage of cardiogenic shock, as we have discussed. There's a different definition of the cardiogenic shock regarding cardiogenic shock trial, IBP-SOAP trial, EHS-PCI, and ESCH, heart failure, and Cameron NIH. So what the shock trial said, that when systolic blood pressure is less than 90 for more than 30 minutes, vasopressor support to maintain blood pressure more than 90, along with the decreased urine output, patient have a hemodynamic criteria of cardiac index less than 2.2, along with the raised pulmonary capillary pressure. So the end organ hypoperfusion, regarding ESC definition, end organ hypoperfusion and hypoxia are the leading cause that may lead to damage. The primary cardiac disease. So the hypoperfusion, as we discussed, the systolic blood pressure less than 90 for more than 30 minutes, not responding to the volume replacement. And there's the evidence of hypoperfusion that show on clinical sign, their cold periphery, oliguric, altered mental status, elevated of lactate, metabolic acidosis, along with derangement of the kidney function and the liver functions. The primary cardiac disease, the infarct related, is 3 to 13% of acute myocardial infarction develop cardiogenic shock, in which 80% because of the left ventricular failure and around 7% because of the right ventricular failure. And mechanical complication may lead to the acute severe MR due to rupture of the papillary muscles. There's a ventricular septal rupture, seen 4% three-wall rupture, and formation. They may lead to the cardiogenic shock. So these are the mechanical complications that may lead to the worsening of the shock, and it may need early discussion with the surgeon. They need a heart team discussion for the management of mechanical complication. It's a class 1 indication, catastrophic. Whenever patient having a papillary muscle rupture, patient present with acute pulmonary edema, there will be a MR on echocardiogram. You can see a mobilized mass in the LV that prolapsing to the LA. Whenever patient having a septal defect, it may be asymptomatic to circulatory collapse, and there will be a left to right on echocardiogram, and there will be a high continuous wave Doppler velocity of the CW. Pseudoaneurysm, asymptomatic, having a chest pain or heart failure, maybe a small neck communication, and there will be a to and fro blood from through the rupture. The free wall may lead to circulatory when there may, because of the pericardial effusion and cardiac tamponade. So the shock management in acute myocardial infarction may leading to the LV dysfunction, systolic and diastolic, that may elevated and diastolic pressure, edema, further aggravate the hypoxemia. They all because of the ischemia that may progress to LV dysfunction and death. So the different stages to start whenever patient having hypertension, you start the inotropic support, vasopressor, and patients, if patient is not responding to these inotropic or vasopressors and support, the mechanical support, they have a mechanical device, balloon pump, LVAD, ECMO, and Impella. And the primary reperfusion is the class 1, it's better to reperfuse and decrease the ischemic burden. The pillar of management is the diagnosis and risk stratification due to MI, emergency revascularization, and management of the acute myocardial infarction, restoring end organ perfusion by giving support to the patient. You need a general support to wire that starts from the emergency department into the CCU, and mechanical circulatory support. The selection of the patient is very important for the mechanical circulatory support. So this is, we already discussed the acute ischemia combined with the clinical presentation, ECG changes, and rest troponin. And the evidence of hypoperfusion is there will be a volume overload state, patient may have dyspnea. The immediate echocardiogram to see any mechanical complication is a class 1 indication. You have to do a brief echo or the emergency to see the left ventricular dysfunction, pericardial effusion, any mechanical complication that worsening the cardiogenic shock. You assess the IVC and you differential diagnose and help see the lung B lines. Their comprehensive study of echocardiogram to be done after 12 hours or in the CCU or after revascularization. So revascularization is emergent in both STEMI and non-STEMI, regardless of the time since symptom onset. But shock trial says that early revascularization versus initial medical stabilization, the mortality is similar in initial 30 days, but it improved in 6 months, 1 year, and 12 years. PCI and CABG, there's no any difference, but PCI is the gold standard because majority of the patients undergo PCI. Whenever there's a failed in PCI or patient having not amenable for PCI or any surgical, any mechanical complication, you get consulted for the CABG in these patients. Radial access is preferred in non-shock patient. There's evidence, but in cardiogenic shock, the meta-analysis of 8,000 patients, they show the lower the mortality, the spare femoral access for the mechanical security support device, depend up the palpability of the pulse and operator. Because the radial access, if you get a femoral access, the complication, exercise complication, they are very high. And if you take access from the radial, you have a spare femoral side access for mechanical support. 70 to 80% of the patient have a poor prognosis time. They present with a multivessel disease. But culprit shock trial says the culprit only versus total revascularization. The culprit only vessel revascularization have a lower mortality, and renal replacement therapy with culprit only and straight PCI of revascularization and anti-hospitalization are discharge. The revascularization, you can see the fibrinolytic, there's no any sufficient evidence available for the fibrinolytic and cardiogenic shock. Only if the early revascularization is not feasible, ST elevation MI. The choice of antiplatelet is very difficult in shock patient because there be impaired absorption, impaired hepatic activation of the clopidogrel that's more commonly used in our part of the world. Need for reversibility and presence of heavy thrombotic burden. The IV cangrelor is new drug that is the 100% bioavailability. You give intravenous, it's a rapid onset and rapid offset. It is seen in a DAPT shock, MI trial, it's class 2 indication shock patients. Other antithrombotic unfraction heparin usually preferred, rapidly reversible, presence of acute glycoprotein. 2B3 inhibitor may aggravate the bleeding, and in small RCT failed to prove any superiority. Can be used in patient having a heavy thrombus burden. Management of mechanical complication, you need a heart team decision, acute severe MR mitral valve replacement is a class 1 indication or repair pen. And ventricular septal rupture is a surgical or intervention closure, class 1 indication. Early versus late closure, there's more mortality as compared to delayed. But there's a selection bias because majority of the patients are present with a ventricular septal rupture earlier. They have the necrotic and very fragile tissue, so difficult for the surgeon manage. And the mechanical circuit support device could buy a time for the therapy. Free-wall rupture, you need a pericardial synthesis. So begin in the pre-hospital phase and emergency department. The perfusion target blood pressure, you should have to keep the blood pressure more than 90, and the map should be 60 to 65 millimeter. Okay. Fluid challenges, class 1. If no overfluid overload seen, initially you can give a 250 milliliter of normal saline or inhalectate for over 15 to 30 minutes, and it's be echo-guided to see any increased stroke volume in U volume equation, and extra care in RV dysfunction. Fluid may need more intervention present in fluid. The maintenance of perfusion, pharmacological circulatory support. 90% of the cardiogenic shock need a pharmacological inotropic of vasopressor. It may increase the width of circulation, afterload, and impair micro circulation. The lowest possible dose, the support should be lowest, and for the shortest possible duration. The drug of choice for vasopressor is the norepinephrine. There's no, besides that, there's epinephrine, dopamine, and vasopressor. They have a high incidence of complication, but the norepinephrine is the drug of choice. Inotropic support, you can add dobutamine along with the norepinephrine. General measures have to monitor the blood pressure and clinical hypoperfusion. Arterial blood gases should be seen in patient having a stage B, C, and D patient. Central venous line should be placed in all patients along with the arterial line. Urinary catheterization been done only on those patients who have oliguric or have acute kidney injury. Pulmonary artery catheterization not routinely been done. There's no better, but it may lead whenever there's the assessment of the RV function or uncertain diagnosis. ECG monitoring, X-ray, echocardiogram should be done immediately and after 12 hours to see any complication, along with the lactate clearance and the baseline investigation to see the oxygen and ventilation support. The maintained saturation more than 90%. There's non-invasive ventilation, support of CPAP, but in cardiogenic shock, 60 to 80% patients require invasive ventilation. Better to give ventilator support earlier to avoid hypoxemia or avoid acidosis that may lead to further worsening of the outcome. The lung protective ventilation, the tidal volume should be 6 ml per kg according to body weight. Renal replacement therapy is the following standard indication. 1/3 of the patient develop acute kidney injury. The kidney function usually recover after the recovery of the shock. 14% of the culprit shock trial patient require RRT. The early RRT before indication, there's no any benefit patient found in those. You go for the early RRT, but whenever there's indication, go for the renal replacement therapy. The continuous veno-venous hemofiltration is more than intermittent hemodialysis. Keep the glucose level 144 to 180, and there's no nutrition. They're known in early phase because then possibly if you want give parental nutrition, because the early phase there's more GI complication with early enteral feeding. Target temperature monitoring is encouraged the post-arrest as general guideline. Avoid if post-arrest shock pool trial, no benefit or increased lactate. So those patients who have a cardiac arrest, the target temperature monitoring is no other. Breathing problem, transfusion indicated when there is a hemoglobin less than 7 grams and having a restrictive transfusion strategy. You have to give gastro protection and the prophylaxis patient. Mechanical circulatory support is emerging role in cardiogenic shock, improve hemodynamics beyond disease capability. The limited RCT data on effectiveness, safety, and the timing. The success depend on proper patient selection, proper device selection, prevention, or management of the complication. The patient selection should be less than 75, they have good neurological status, have comorbidities, and stage of cardiogenic shock, A and C. These are the mechanical security support device, entire balloon pump, impella, tandem heart, VA ECMO. Even you can use the tandem heart, impella, and VA ECMO in RV inform, biventricular. So the device selection, because the entire balloon pump is inserted through the femoral artery to aorta, and it has a pneumatic pump that inflate during diastole and deflect during systole. It has a pulmonary activity, the intracorporeal. It supports 0.5 to 1 liter per minute. And the impella have indicated in LV and RV failure, the electronic pump. It has a continuous machine, and they have a 2.5 impella CP. It supports both the LV and the RV. Tandem heart is also support the left ventricle and right ventricle. We can place to the femoral artery into the aorta A-line and to the femoral vein into the left ventricle appendage, the interstitial puncture. The right side we can place from the IVC to the pulmonary artery. So the VA ECMO is also placed through the femoral artery, aorta, and from femoral vein, the venous access to femoral vein to the right atrium. The electronic rotatory pump that is a continuous flow, it is a centrifugal, extracorporeal, and the duration of these mechanical support devices around 3 to 4 weeks. And it has a good support power, 7 liter per minute VA. It can support both RV and the LV. Most of the device, they decrease the afterload, but tandem heart and VA ECMO, they increase the afterload. There's a gas exchange in VA ECMO. And there's a pulse dependency seen in intra-aortic balloon pump, but there's no any dependency of pulse in impella, tandem heart, and VA. Contraindication, acute aortic regurgitation, severe aortopathy, aortic hernia. It is contraindicated for balloon pump, also impella, because you have to go through the aortic wall and severe aortic stenosis, patient having peripheral artery disease, LV thrombus, VSD. They are the contraindication for the impella device. Tandem heart, patient having severe aortic regurgitation, dissection, VSD. These are the contraindication you have to look for before starting a mechanical circulatory system. So there are different trials that have been done with the intra-aortic balloon pump, impella, tandem heart, and VA ECMO. IABP Shock 2 trial that was compared with the balloon pump with control. There's no any mortality benefits seen. Impella with IABP was compared with impress and severe shock. There's no any mortality benefit seen. Even in tandem heart, there's no any mortality benefit was seen in 2 different trials. But VA ECMO has significant mortality benefit and there's improvement. But in mechanical circulation, there's no vascular complication because of the large node access. These are the devices we can use for the cardiogenic shock with predominant left ventricle failure. You can place impella, VA ECMO, and you can see the impella and VA ECMO can be placed in all. In summary, the cardiogenic shock is a common cause of mortality, complicate 5 to 10% of the SS. Acute MI shock may lead to diminished cardiac output and organ hyperperfusion and hypoxemia. In acute myocardial infarction, accounts for 80% of the patient in cardiogenic shock. The ST segment elevation myocardial infarction is associated with 4 increased risk of development of cardiogenic shock compared to non-ST elevation infarction. The high incidence of cardiogenic shock are observed in women, Asian, Pacific Island, and the patient who have an age more than 75 years. The optimization of care require a multidisciplinary team effort. Advances in systemic recognition and classification of acute myocardial infarction cardiac shock are expected to follow a new wave of clinical investigation to this highly morbid and mortal disease and its invasive management. So, and the right ventricular infarction, around 7% of the patient, they develop cardiogenic shock. It's complicated 50% of the patient who have an inferior wall MI, they develop right ventricular infarction. It's associated with high in-hospital mortality and morbidity, right ventricle failure, and elevated right ventricle filling pressure despite relatively normal left ventricle filling pressure. Shock with RV infarct reduce LV preload and involvement of the interventricular septum adversely affect the left ventricular function. Reperfusion facility for RV recovery and improve even after prolonged oxygen and in patient with ventricular shock. This is the comparison between right ventricle and left ventricle. It's a thin bar, it's a 2-year, it's longitudinal shorting. Left ventricle, you have a 3 layers, the Torian contraction, sensitive to pressure overload. And left ventricle is sensitive to volume overload. Right ventricle is highly dense density of adrenergic and cholinergic receptor. The left ventricle have alpha adrenergic stimulation, increased contractility. Alpha adrenergic stimulation, reduced contraction. In RV, right ventricle, I have just to yeah. So, if you compare the acute isolated RV infarct, it may lead to the decreased RV preload, decreased contractility, and decreased left ventricular preload. That may followed by decreased cardiac output and increased LV afterload. Whenever there is a biventricular infarction, there will be a decreased preload followed by a decreased ventricular preload, and afterload will be increased, and cardiac output decrease and left ventricular afterload is increased. So the incidence and prevalence of LV infarction is more common than RV infarction, often associated with large myocardial infarction due to the greater muscle mass and high oxygen demand of left ventricle. In contrast to the right ventricular infarction, it occurs less frequently and is typically associated with inferior wall myocardial infarction due to the right coronary oxygen proximal to the RV line. Left to right ventricular failure subsequently to acute myocardial infarction remain the most frequent cause of cardiogenic shock, according approximately 80% of the patient. LV infarct, the clinical characteristics for LV infarct is the symptoms, the patient having severe chest pain, pulmonary edema, significant hypotension, the pathophysiology, the involvement of extensive ischemia leading to LV systolic and diastolic dysfunction, hemodynamics, marked reduction in the cardiac output, high pulmonary capillary wedge pressure, and systemic hypertension. In contrast to the RV infarcts, the symptom may increase tubular venous distension, hypotension without pulmonary congestion, and lung be cleared. Pathophysiology often occur with inferior wall MI and involve the right pulmonary artery. The hemodynamics, elevated right atrial pressure, low pulmonary artery pressure, and preserved left ventricular function, unless extensive myocardial damage occurs. The prognosis and outcome, LV infarct generally has a poor prognosis due to the critical role of the LV in systemic circulation. There is a high risk of developing cardiogenic shock with a high mortality rate. Recovery of LV function is often poor, even with reperfusion. If you, in contrast to the right ventricular infarction, historically considered to have a better prognosis due to the RV thinner wall and low oxygen demand. However, severe RV infarction can lead to significant hemodynamic compromise and increased mortality. The RV function can improve significantly with appropriate management and reperfusion. Treatment response in LV infarction, the primary treatment involvement, the early revascularization, and shock registry utility, the early revascularization improves the outcome. The task of the right ventricle management includes maintaining RV preload by giving fluids, reducing RV afterload, and improving right ventricular contractility. The reperfusion strategy are similarly critical, but the response may vary depending on the extent of RV involvement and associated left ventricular function. Shock registry data revascularization provide modest survival benefit, but overall mortality remains high. The comparative data from the shock trial and other studies, and the shock trial, LV shock, early revascularization, lower 6-month mortality, 1 year and 12-year follow-up data also show a significant reduction in the mortality. The RV shock similarly have a high mortality rate, 53% versus 61% for LV shock, with revascularization imparting equivalent modest survival benefit. Additional studies, the studies have documented the resilience of the ischemic RV and beneficial effect of reperfusion RV performance, hemodynamics, and survival. Despite the RV potential for recovery, severe RV infarction with hemodynamic compromise still result in high mortality. In summary, the left ventricle has a high incidence, severe clinical presentation, poor spontaneous recovery, and significant benefits from early revascularization, but still high. RV infarction is a less common, potentially better recovery with appropriate management, but high mortality in severe cases, with modest survival benefits from revascularization. Conclusion, both LV and RV infarction present significant clinical challenges, especially when complicated by cardiogenic shock. For that, you may also get support from mechanical circulatory support device for RV and infarction. The early and effective reperfusion therapy is crucial for both, but outcome can vary based on the extent of myocardial damage and the specific ventricle. Continuous research and advancement in treatment strategy are essential to improve prognosis and survival rate patient with both LV and RV infarction. Thank you very much.
Okay, thank you, Dr. Ali. I think because of time limited, we must skip the discussion for this section. I will hand the moderator position to the Professor Kasem. Professor Kasem, please. Thank you.
Thank you, Dr. Chen. Welcome everyone to APSC Forum of Cardiovascular Disease. Let me move to the next speaker, the next topic. The next speaker is Dr. Nai-Hsin. He is Associate Professor, Department of Surgery at National Taiwan University Hospital, Taipei, Taiwan. And today he will talk about acute myocardial infarction complicated with severe mitral regurgitation, surgical valvular repair versus transcatheter edge-to-edge repair. Welcome, Dr. Hsi, please.
Thank you. Thank you for the introduction. I share my slide first. Okay, that's my topic. I will talk about myocardial infarction complicated with severe mitral regurgitation. And I am assigned to talk about surgical treatment versus transcatheter edge-to-edge TEER repair. I work in National Taiwan University Hospital in Taipei, Taiwan. First of all, we want to know the incidence of mitral regurgitation after myocardial infarction. Actually, the mitral regurgitation after myocardial infarction accounts for about 30%. And about 3 to 5% who have severe mitral regurgitation after the myocardial infarction. And the mechanism of myocardial infarction actually is divided by two. First is the patient have a subvalvular apparatus rupture. And second is the patient without salvadoral apparatus rupture. Those without rupture is the term we call it ischemia mitral regurgitation, and sometimes we call it functional mitral regurgitation. And first, I will talk about salvadoral apparatus rupture, and sometimes we call it papillary muscle rupture. This prevalence is really very low. It accounts for only 0.05%. However, those patients who had still very high mortality, even those decades past, we still have very high mortality, around 40%. So that is a point that we have unmet surgical or medical treatment for this disease. And most of these patients, they have disease of mitral regurgitation, papillary muscle rupture, frequently happen in the first week and during the first 24 hours of initial presentation. And the papillary muscle rupture actually is a continuous spectrum. It's not only the whole papillary muscle complete rupture. It can go from elongation without rupture to rupture one head of papillary muscle to complete rupture. This is a picture of papillary muscle elongation without rupture. We can see that there's some prolapse over there and papillary muscle elongation over there. And the second spectrum is the rupture of one head of papillary muscle. Those happens, and we can see the mitral valve bileaflet lesion and with severe mitral regurgitation. We can see the papillary muscle head going through the left atrium during the systolic phase. And the third spectrum is the complete papillary muscle rupture. That always is the most dangerous and most critical because they always have torrential mitral regurgitation, more than severe regurgitation, and have very unstable vital sign. So that's the clinical classification of mitral regurgitation after myocardial infarction. Type 1 actually is most critical because they have cardiogenic shock with lung edema, lactic acidosis. Those patients, most of them require vasoactive medication, inotroph, or mechanical support immediately, and require urgent treatment, either surgical or transcatheter edge-to-edge repair. And type 2 is the patient who is not so severe but still have refractory lung edema and with some kind of low cardiac output, oliguria, and normal lactic level. They require continuous diuretic agents and require urgent treatment. Type 3, that is more likely because they have maybe in low cardiac output status, some episode of lung edema. That don't need continuous diuretics, only intermittent diuretic agents, and need a valvular intervention. Type 4 is the patient with only mild to moderate heart failure, and the role of valve intervention is uncertain. But those patients in the long term, they will have left ventricular remodeling. That is not good for the patients. And the mechanism of acute mitral regurgitation goes from some elongation or part of the piece of papillary muscle rupture to the whole piece of rupture. And the other kind is, we call it functional mitral regurgitation. The dilated ventricle pull the posterior leaflet away, tethering, and cause mitral regurgitation. And first, I will talk about surgical approach. Actually, the timing of surgical approach influences the outcome, but this is actually a selection bias. We operate earlier, the mortality is 20% in emergency indication. And if we can operate electively in functional MR, the mortality goes down to 4%. But remember that it's a highly selective bias. So the timing of surgery most determined by the hemodynamic status of the patients. And the surgery, we have a mitral valve replacement by mechanical valve, by bioprosthetic valve. This is replacement. We also can do repair by any kind of methods. However, repair first replacement in those patients fail to show the difference in the long term of LV remodeling or survival at 1 and 2 years from surgery. That means repair and replacement offers almost equal in this kind of disaster patients. But if we repair the patients, they have higher mitral regurgitation recurrence rate, and they have higher readmission rate for cardiac cause. So actually, there's not much room for mitral valve repair in these kind of patients. If we go for surgery, mitral valve replacement is better in this kind of scenario. So, but when we go for mitral valve replacement, the result actually is not good. The mortality is still high. But if we don't do those surgeries, we go for medical treatment, the mortality is 80%. But if we go for surgery, the mortality is still high. It goes from 12 to 40% of mitral replacement in those patients. So surgery for those patients carries high risk, about 12 to 39%. And mitral valve repair actually has not much room for these patients. If we go for surgery, it suggests we go for mitral valve replacement rather than repair, because we repair the patients, they have higher recurrent mitral regurgitation in the long term. And when going for surgery, coronary bypass grafting, in the context of myocardial infarction, popular muscle rupture, is very essential. It's the only independent predictor to improve early outcome. So when we go for surgery, additional coronary bypass should be carried on in those kind of patients. And actually, in the evidence that most of the patients, they don't go for surgery, that is because of they are in a very bad condition. In the early series, the Shah trial, those kind of patients, only 38% of them go for surgery. More than 60% of them were refused for surgery because of poor condition of the patients. And the recent European studies, a large cohort, only 60% of patients receive surgical treatment. That means another 40% of them are not good enough for surgery, and those patients will die. And the other topic I will talk about, percutaneous approach. That is we call TEER or TEER with mitral clip. Mitral clip actually is the largest clinical experience in this kind of percutaneous approach. And it's safe and effective to reduce mitral regurgitation in high-risk patients. And it's less invasive, and this can go more and more adopted in recently. And in this study, they collect all the patients in Europe with mitral regurgitation due to popular muscle rupture. This is the largest series of popular muscle rupture treated by TEER. And all patients, these patients are turned down from surgery because those patients, the Euro score was high, it was 27%. And TEER successful treats in 87% of the patients. However, the in-hospital mortality was 30%, we look at these two numbers, 27% Euro score 2, 30% in hospital mortality. Actually, this treatment didn't change a lot. The mortality is still high, but acceptable because they can take the patient into further treatment. So in those patients, 22% of the patients in the follow-up receive elective successful surgical treatment of mitral valve replacement. That means TEER actually support the patient and make them go for elective surgeries that decrease the surgical mortality in the future and turn the patient from the salvage surgery to urgent or to even to elective mitral valve replacement. So that's you can see that even the patient have papillary muscle rupture, they can treat successfully by TEER and stabilize the patients. And the other topic we should talk about functional mitral regurgitation, because the other mechanism of severe MR is the patient with functional mitral regurgitation. In the functional mitral regurgitation, actually, most of the people are suitable for TEER because it's even easier than papillary muscle rupture. So the technical successful rate was 86%. Mortality rate is 9.1%. And they can have almost 75% return to functional class 1 or 2 in the follow. And the patients have a functional MR is a good candidate for TEER. We see that the patient gets solved by TEER and the mitral regurgitation disappeared. And we compare those patients. This is a study after acute myocardial infarction with mitral regurgitation treated by mitral clip in severe mitral regurgitation. They can have equal survival even they have a cardiogenic shock or non-cardiogenic shock. So that's very good for this approach. This means when we go for TEER, we can change the cardiogenic shock patients, the result equal to the non-cardiogenic shock patients. So that's a good treatment choice for patients with functional MR with cardiogenic shock. And talk about when we should choose surgical procedure, we must to know the potential drawback of percutaneous approach and the strength of surgical procedure. I am a cardiac surgeon, so I search about which procedure is good for surgery in those kind of patients. So first, when we do TEER in this setting, actually for cardiology, some technical challenging because acute stage left atrium is small and non-compliant. That make the procedure difficult in the non-experienced hand, and not all the center with good, excellent experienced TEER team all the time. And second, if the patient with papillary muscle rupture, flail segment is a large area, and most of the time those flail segments are over commissure lesion. Commissure lesion actually is difficult to treat by mitral clip. And the progressive left ventricular remodeling will reduce the effective mitral valve competence in the future. But I think these are not the reason we should choose surgical procedure, because surgical procedure actually still carry high risk in the salvage surgery or emergency surgery. It carries about 20 to 40 mortality rates compared to TEER treatment. We can see that we go for mitral intervention, those patients get better than conventional surgery and also better than surgical mitral valve replacement or percutaneous mitral valve replacement. That means actually I think there's little room to compare with TR with surgical treatment for mitral valve replacement in this very disaster patient scenario. But I think we should increasing the role of mechanical support because we should change those patients into stable condition from salvage surgery to emergency surgery to urgent surgery and then to elective surgery. So we can have better outcome in the long term. So we cannot say which one is better. We should choose a hearting approach to make the patient stabilize and have more room for surgical treatment so they can have better outcome in the future. So we should use more mechanical support to make the patient stabilize. And we can consider to go for a mitral clip first, stabilize the patient. Once the patient stabilize, in the long term, we go for mitral valve replacement by surgery. So there's a lot of mechanical support. I think we just have shown by previous speech, so I won't talk too much about this, but those mechanical support all have some benefit in this kind of scenario. So this is some proposed scenario. We search for symptomatic patients with severe mitral regurgitation after myocardial infarction. First of all, revascularization is important. We should always revascularization first. And if the patient is clinical stable, then we can search for the mechanism of mitral regurgitation. If this functional mitral regurgitation, mitral clip actually wins, and we should go for the TEER first. If the patient has papillary muscle rupture, and if the patient is not stable, I think TEER also works. It could decrease the mitral regurgitation, stabilize the patient. After the patient stabilized, and we go for surgery. And if not stable, it's very important to put the mechanical support to make the patient stable so we have further treatment choice. This is a busy scenario, but I think most of the thing is the same. First, we should go for revascularization, and we looking out for the mechanism of mitral regurgitation. If the mechanism is functional, and if the myocardium can recover, we wait and see. And if the myocardium is not recovered, if they stable, we go for surgical candidate. If not stable, we should all go for mechanical support to make the patient stable. Remember that those patients, in the past time, only 40% go for surgery. Recently, only 60% go for surgery. That means 40% of them, we lost them because unstable. So we should stabilize them and make them even stable by mitral clip TEER. And if they can be more stable, and then we go for surgery. So this hard teamwork, and we can change the scenario that surgical outcome is poor and those patients have poor long-term survival by this approach. So my last slide is that we should stabilize the patient first and operate later. I should say that TEER actually wins versus surgical replacement, but I think those are team approach. We should seek for the patients who is better for surgery in the long term, and we should stabilize the patient by mechanical support, by TEER. Then after everything stabilized, we operate in elective patients, and we can have long-term durability of mitral valve, and we can have better long-term outcome. Thank you very much.
Thank you, Dr. Shi, for your nice presentation. The acute severe MI is very high mortality in patients with acute MI, and I agree with you that assessment of mechanism and severity of mitral regurgitation after acute MI is crucial and important. My question is, do you think what is the proper timing of surgery or tear in patient we can stabilize with the mechanical circulatory support in severe MR?
Okay, thank you for that. The best timing is we can have elective surgery. That is, we put, if the patient is very bad, we put mechanical support for them. We put either ventricular assist device to decrease the lung edema, to solve those problems, to treat the end organ dysfunction. If the end organ is stabilized and everything is okay, first we can choose TEER first. We can choose mitral clip first. Mitral clip could actually decrease mitral regurgitation in this kind of patient in acute phase. That decrease the mitral regurgitation. And if the patient gets stable, we can gradually weaning off mechanical support. After everything is okay, we search for the long-term outcome. If we need the long-term durability of mitral valve and we need to reverse remodeling of mitral valve of ventricle, we can go for coronary bypass with mitral valve replacement in the elective condition. That make operation mortality lower and increase long-term durability of mitral valve and in those patients.
Okay, thank you so much. And we will move for the next topic and next speaker. Dr. Tsai, please introduce for the next speaker.
Okay, thank you, President Dr. Kasem. I'm Dr. Tsai from Taiwan, and the next talk, we are very happy to have Dr. Kit Bhumimuang from Thailand, who is a structural heart intervention cardiologist in Thammasat University Hospital. And she's gonna to deliver a talk entitled with Acute Myocardial Infarction complicated with ventricular pseudoaneurysm and free wall rupture, transcatheter closure or surgical repair. So Dr. Kit, please. Thank you very much. Thank you.
Thank you for kind introduction. My topic is about AMI complicated with ventricular pseudoaneurysm and free wall rupture, transcatheter closure or surgical repair. I have no conflict of interest. So for introduction, post-MI ventricular free wall rupture is a lab mechanical complication less than 0.01%, but this complication can lead to death within a minute. So early recognition and management is more important and may reduce mortality in this patient. And novel developments in the field of transcatheter-based treatment may be alternative treatment in this group of patients. So I will overview about the pathological and anatomical classification and diagnosis, pre-procedure, hemodynamic treatment, surgical repair, and transcatheter treatment. So for the pathological and anatomical classification, from 1975, publication from Becker, from the autopsy case of ventricular free wall rupture, they show the Becker classification of cardiac rupture into 3 types. The type 1 is slit-like rupture with myocardial hemorrhage. and most often associated with severe cardiac tamponade and often associated with treat with fibrinolytic. And the second type is type 2 rupture with erosion. This is less progressive, but also can associated with pericardial effusion causing tamponade with myocardial hemorrhage also, and associated with treat with primary PCI. And the third one is less progressive. It's called early aneurysm formation in type 3 Becker classification. And you will see that this type is no myocardial hemorrhage and associated with patients that didn't receive the reperfusion therapy. After that, in 2019, Matrosi was classified the type 1 Becker into blowout ventricular free wall rupture and the type 2 into the oozing free wall rupture. Is the same? And maybe we can classification by the duration that acute is mean within 2 weeks and often associated with severe clinical, so urgent surgical repair may be needed. And for the chronic occur more than 3 months, can be symptomatic or asymptomatic. And if patient have symptomatic or asymptomatic that pseudoaneurysm is more than 3 centimeter and expanding, so surgical repair will need. But it's less than 3 centimeter with non-expansion, maybe follow up the patient. This is summarize the clinical characteristic and pathological characteristic according to the type of ventricular free wall rupture. You can see the blowout or Taiwan Becker classification often acute cause, and pathological, as I said, is myocardial tap and rupture with hemorrhage and cause cardiac tamponade. And most clinical may be cardiac arrest or cardiogenic shock or new chest pain onset. For the type 2, it's oozing type. Cause is subacute with myocardial erosion, often associated with intramyocardial hematoma and serpiginous cause, and maybe progressive pericardial effusion, and clinical maybe cardiogenic shock and hemorrhagic instability or even mild symptomatic. And type T is chronic or subacute, so pseudoaneurysm type with fistulation and no myocardial. The pseudoaneurysm, no myocardial layer, only the fibrotic cap with pericardial effusion and clot, and containing by epicardial clot and pseudoaneurysm with fistulation. And clinical, most of them variable from the asymptomatic to incidental diagnosis. So for the lead factor of ventricular free wall rupture, from publication of Honda in 2014, they used numerous of factor to take into account. So the factor that is a lead factor for ventricular free wall rupture is age over than 20, female, underlying disease hypertension, and delay time of reperfusion. However, primary PCI was protective lead factor for ventricular free wall rupture. So in terms of diagnosis, the mainstay of diagnosis is the echocardiogram. In both figure, you can see the pericardial effusion causing the cardiac tamponade and concealed rupture. And intraventricular, you can see the apical thrombus and apical thrombus. For the echocardiogram, you can see the location of the rupture and epicardial clot, and sometimes reduce of myocardial wall thickness and the asset ventricular function also. And for the LV pseudoaneurysm, this figure show the neck of the LV pseudoaneurysm and outpouching of the ventricle without complete myocardial layer. And for turn on the color, you can see flow across from the left ventricle to the pseudoaneurysm at the neck part. In addition, you can use the real-time 3D echo for demonstrate the whole of the neck of the pseudoaneurysm and to demonstrate the geometry and complexity of the orifice that connect between pseudoaneurysm and the left ventricle. And turn on color, you can see flow across and complexity of the orifice. So this figure shows difference between pseudoaneurysm and a true aneurysm. For the pseudoaneurysm, it most often has narrow base or narrow necks, and the wall of pseudoaneurysm composed of the thrombus and pericardium, and this is high risk of rupture. Another tool for the diagnosis is a left ventricular angiogram. As you can see, the left ventricular angiogram, this is show the outpouching contrast extravasate from the left ventricle to the pseudoaneurysm. And from the left ventricular angiogram, you can see location and site of rupture and also ventricular function. In the right figure, you can see that extravasation of the contrast into pseudoaneurysm. This can be used for diagnosis and also can be used to assist procedure during transcatheter closure as the echocardiogram. And in some patients that hemodynamics stable, the CT imaging can be used to define the complexity of the pseudoaneurysm or define the size of the rupture. At this figure, you can see that the contrast fill in pseudoaneurysm, and the right figure you can see that contrast outside the left ventricle to form in the pseudoaneurysm, and can see the size of the neck of pseudoaneurysm to incorporate with assist to surgical repair or transcatheter treatment. And also in stable patient, we can use 3D printed heart model to assist our intervention. As this case, you can see that they print heart model to demonstrate the pseudoaneurysm and the neck size, and see how the device optimize deployment in the pseudoaneurysm and how to access to the pseudoaneurysm also. So another investigation, if patient is stable, is cardiac MRI. As these three figure, you will see outpouching of the contrast through the left ventricle and also the neck of pseudoaneurysm. And with late gadolinium enhancement, you can identify the scar tissue, non-viable myocardium, and sometimes the clot in the pseudoaneurysm and the sac of pseudoaneurysm. You can evaluate burden or amount of the non-viable myocardium to assist for the surgical treatment or revascularization option. So for in terms of procedural treatment, it's crucial to do the best poly-procedural hemodynamic treatment also, including the medical treatment and temporary solution. The hemodynamic support may be by the medication. I won't get into the depth. And the mechanical supporting device that be used in cardiogenic shock. And for the critical care management, include pre-procedure, during procedure, and after surgical repair. I mentioned only that why after surgical repair, because we need to like LV unloading to reduce ventricular tension and also to control blood pressure to prevent recurrent ventricular fever rupture after the procedure. First one, for the treatment, I will talk about the role of surgical repair. It is standard treatment of ventricular fever rupture. This figure shows various techniques of ventricular fever rupture surgical repair, including direct linear closure, pad closure, and also sutureless repair with collagen sponges. This all data didn't compare success rate or the complication between this, but some data show that the sutureless repair may increase rate of recurrent rupture a little bit, but optimal surgical technique is still debated until now. In terms of ventricular pseudoaneurysm, both direct defect closure with suture or plate closure over the area of viable myocardium has been proposed. For the survival after surgical repair, this publication from 2022 review case that post-surgical repair of all post-MI complication. If you select only left ventricular free wall rupture after surgical repair, in-house mortality is so high, about 35%. But in 5 years and 10-year long-term survival, maybe after patient survive from the hospital, the survival may be around 80%. Regarding revascularization, this meta-analysis compare between cuff bed versus non-cuff bed integrate with ventricular free wall rupture repair. This demonstrated that there's no impact of cuff bed on early or late mortality in this patient, in patient that underwent ventricular free wall rupture repair post-MI mechanical complication. For the according to the high surgical risk, so transcatheter treatment have been developed. For the free wall rupture, there was publication from Dr. Terashima in 2008. They used fibrin glue injection for treatment of free wall rupture. So among 22 patients, the 9 patients who stable after pericardiocentesis, the fibrin glue was injected in pericardial space without the immediate complication. For the results, 1 patient go to surgical repair and 2 patients has a re-rupture and lead to in-hospital mortality, and 5 patients can discharge with free of cardiovascular event with mean follow-up 5 years. So for the subacute and chronic pseudoaneurysm, there is numerous data using the cardiac device to occlude at the neck part of pseudoaneurysm. First case report was done by Dr. Cliff from 2004. This case, as you can see, the pseudoaneurysm with neck size is about 12 millimeter and was occluded by the septal occluder size 12 millimeter. This is the first case report about the percutaneous device closure of the pseudoaneurysm of the left ventricle. Then after that, the numerous series of the percutaneous closure of PSA. And for device use, there are various devices but used for closure PSA, including septal occluder, muscular VSD occluder, and in the polymembrane type and muscular VSD occluder type, and also ADO2. And this is show approach for the transcatheter closure. Most often the time they use retroaortic approach. In this case, as you see the pseudoaneurysm, and by echo imaging, you can see neck is size 6 millimeter. And for the CT, you can see the size of the pseudoaneurysm. They use the retroaortic approach to get the catheter in the pseudoaneurysm and close with 6 millimeter and plus septal occluder successfully. This summarizes the publication of the case of percutaneous closure of PSA. As you can see, that most often size of the neck is about less than 20 mm, and they use VSD, ASD device, and also ADO2 device. Some of them the size beyond 20 mm. For the access, more often the retrograde, but some, as you can see, they can come from the direct chest wall entry or apical puncture. For the retrograde approach, you can come from femoral artery or axillary artery, brachial artery also. It depends on how length of the delivery system can be used. And for the results, as you can see, almost completely occluded with some complication. So the complication of the transcatheter closure of the PSA is among this acute renal failure, hemolytic anemia, and pericardial effusion, device embolization, and also arrhythmia, and incomplete closure, and ischemic stroke. So the main fundamental elements for successful closure for the transcatheter approach is accessible transcatheter access route that allow for the favorable delivery catheter angulation, either via trans or retroaortic or transeptal antegrade approach, and adequate interprocedural imaging, and also favorable PSS anatomy with discernible neck width and aneurysmal sac depth to allow for safe manipulation and implantation of the percutaneous device. So I would like to summary in VSR management as this figure proposed by Lasso 2022. In acute MI that complicated with ventricular free wall rupture, you should divide into the blowout type or Taiwan, and Yih-Sharng type or type 2 Baker, because this can cause hemodynamic unstable and cardiac tamponade. And second thing, you should consider about surgical risk to be whether patient has can be surgical candidate or not. If patients can be surgical candidate, surgical option should be offered with mechanical support or medication that support hemodynamic. For the case with ventricular pseudoaneurysm, often asymptomatic and hemodynamic stable. So after multimodality imaging and patient and clinical assessment, surgical candidate should be considered. If patient can be surgical candidate with low surgical risk, surgical option should be offered. But however, if patient have high surgical risk, percutaneous closure may be considered instead. Thank you.
Thank you very much, Dr. Kidd. Very informative and comprehensive talk. I got a question. Do you routinely use 3D transthoracic echo for evaluation those AMI free wall rupture cases in ED?
I think the role of 3D echo, if you get the 2D echo image clearly, you can demonstrate 3D clearly, and 3D can help us to define the size of the rupture, because you can flip the image to see whether the blood leak from which size, and you can see the configuration and complexity of the tract or channel that leak from the ventricle.
And I noticed that you demonstrate a model that's a 3D printing, right? 3D printing heart. So do you use this kind of modality before doing the surgery or before doing the transcatheter based intervention, or just a demonstration?
Actually, honestly, I pick up from the publication. And in Thailand, it's difficult to do the 3D model printing. But I think if some case that like complexity, or you may not sure that device or surgical should be done exactly by which way, I think 3D modeling can be used.
Yes,
But
thank
to
you.
get
Yeah.
the data from the CT that accurate before.
Okay. And by the way, do you have any experience of let's say because of the previous speakers like Professor Ji and Professor Ali Shah, and do you have any experience of, I mean, hybrid? You perhaps you do the catheter-based occlusion first, then stabilize the patient and proceed to the next stage of the definite surgery repair.
For me, I think that
Thank you very
for me, I think that from the case series that they done the transcatheter closure, most of them are pseudoaneurysm. That I mean that clinical is like a more stable.
Okay.
One publication that done in stable patient that like Taiwan or Thai 2 Becker feeble rupture only 5 go injection but small series, and I found only 1 series.
Okay.
But for the pseudoaneurysm, I think it's like a more stable patient.
Do you think if the patient is suitable, let's say, of the occluder in pseudoaneurysm cases, do you think occluder plus thrombin injection is much more safer in this kind of in this group of patients? And yeah, actually, no evidence, right?
I don't see the evidence, but one thing that I think you should aware that the like device you should seal completely, because if you inject glue and the like glue leak into the LV may be like
Yeah,
cause
tragedy.
complication.
Yeah. Okay, thank you very much. Okay, so Sensei, Dr. Kasem.
Yeah. I think 3D printing will be used more in the future in some select patient with mechanical complication, in the some select patient with the chronic case. For example, for pseudoaneurysm, for select some device if we would like to do the transcatheter. Okay.
Thank you.
The next, let me move to the next topic. The next topic is acute myocardial infarction complicated with ventricular septal rupture, surgical repair or transcatheter closure, and we will present by Dr. Hsiao-En Tsai. He is Director of Clinical Care Medicine, Attending Physician of Cardiovascular Surgery, National Taiwan University Hospital, Hsinchu branch in Taiwan. Welcome, Dr. Tsai, please.
Okay, thank you very much for your kind introduction. And I would like to share my presentation slide. Okay. Okay, everyone can see that. Okay. Okay. Thank you very much. And I would like to thank Professor Yih-Sharng Chen and Professor Nai-Hsin. They are both my mentor in cardiovascular surgery. And today I'm gonna give you a talk regarding to acute myocardial infarction with rupture ventricle septum, which is also a very complicated terms of the mechanical complication in AMI. And I'm gonna show some repair case, and but the transcatheter closure experience in my institute is so rare. So probably I just go through some literature review. And since we are a little bit behind the schedule, so I will make it quick. This is a 51-year-old male with hypertension smoking history, and he visited to the other hospital because of STEMI, and they do a very good PCI. However, 2 days later, cardiogenic shock developed, and we identified a posterior wall VSD, so that the patient was transferred to my institute for following treatment. Initially, A very severe cardiogenic shock with daily acidosis were noted. You can see that you can see the acute kidney injury, liver injury, lung edema developed. And we stabilized the patient initially with IABP, ECMO, and we rechecked the coronary angiography. We show the pattern coronary arteries without any acute instant restenosis, so that the PCI was still good. However, complicated a kind of delayed mechanical complication, VSR. And because we stabilized the patient and the O2 demand decreased and the inotropes agent were tapered down slowly, and all the end organ functions are stabilized during days after the MCS support. So you can see the creatinine level, bilirubin level, liver enzymes were all improving gradually. So we proceed to the staged operation. This is TEE, and we can notice that the posterior wall septal ruptured ventricle septum was very clear. And what we do, we just enter into the posterior wall, LV posterior wall, and we see the rupture site, and we closure with the vascular graft with the single PTFE patch, and we repair of the incision with the patch repair. Here's the photo. This is the patient right side, and here is the patient's left side. Is the cranial and caudal. We just elevate the apex upward to the ceiling, and here, here's the inferior wall. We made an incision from the inferior wall, and we can see the rupture site. We just repair with this vascular patch. This is after repairing the vascular patch. We are going to repair the incision site with we call the Mpanda patch, 3-layer, composing with double layer of bovine pericardium, and one in the middle is a darkroom patch, smoothly. And you can see after the repair, the shunting just disappear. And luckily, we can remove the balloon pump on the next day. We remove the ECMO 3 days later from the surgery. And we remove the endotracheal tube 4 days after the surgery. And the patient was discharged from the hospital 18 days after the surgery. So you see a very improving left ventricular ejection fraction from 20% back to 48%, but still complicated kind of functional MR moderately. And the patient can ambulate smoothly, functional class 1, probably less than class 2, with some heart failure medication for sure. Okay, Dr. Ali Shah had already demonstrated that AMI with mechanical complications showed a very high mortality condition, and AMI VSR is a very low incidence, only less than 0.2% among AMI cases. But even after the PCI technology involved or progressed, but still the high mortality of this kind of mechanical complication in AMI cases. And the surgery remains to be the gold standard, but we got many choices of surgical repair. For example, we can just a primary repair of the defect, or we can just try to exclude the infarction area and repair the defect. Many methods, many different ways to solve this kind of complication surgically. And how to do it? This is a kind of modified surgical techniques from the surgeon's point of view. We use this double patch technology from the right side and both from right side and left side in order to decrease the residual shunt. But this is, of course, very technical demanding and time consuming, and probably with a higher surgical mortality. Delayed VSR closure is associated with better survival. And actually, Professor Chi has already demonstrated that this is a kind of a selection bias, since once we stabilize the patient, actually we can do it slowly and we have a better outcome. So we should try our best to probably stabilize the patient even under some mechanical circulatory support or kind of a catheter-based intervention before definite surgical repair. And we got plenty of MCS choices, and the most popular form or combination form of MCS in Taiwan is VA ECMO plus IABP. And actually, we do have Impida, but the cost of Impida still remains high, so that majority of cases is still supported by ECMO and IABP. This is a algorithm that the Hsiao-En approach. The first is that once the patient with myocardial infarction complicated with VSR, we should stabilize the patient first, either under IBP alone or IBP MCS. But still some transcatheter closure choices that say if in stable patients, if the patient is not suitable for surgery, probably transcatheter closure is a kind of choice. If the patient with a severe form of cardiogenic shock inoperable, probably we choose the transcatheter closure as a palliative treatment. But if some unstable patients who is stabilized with certain form of MCS, let's say ECMO, something like that, and when we are going to proceed repair a closure device can also be taken into consideration. This is another review, and we can see from the 2004 to 2013 couples of series demonstrate that they have a small scale of the cases, but the 30-day mortality remain high. And this is a catheter-based closure of the VSR. But the most common consensus now is that probably this kind of catheter-based closure can be a kind of bridge to surgery. We can use this kind of device for some certain group of patients and stabilize this group of patients before surgery or before they are dying. And there's still some rupture site. This anatomical rupture site is not suitable for closure device. So surgical repair remains to be the gold standard, even though the outcome of the surgery stays very similar compared with decades ago. And from one single center retrospective review, it shows that the surgery repair remains be a higher survival rate compared with the percutaneous closure group. But I think there remains some selection bias, since the stable patient can suffer from the surgery. The more unstable patient probably will just proceed to the closure device. So there's still some bias in this study. But we can see there are still some different points. Let's say some condition that we can choose the percutaneous closure. Let's say simple defect, a smaller size, and sufficient anatomical size, margins, rings, something like that. But if the patient is with more complexity defects, let's say multiple defects and a larger size of the defect, and we are going to proceed concomitant CABG or some complex procedures in the open heart surgery, we would suggest to use the surgery repair instead of catheter base. So in conclusion, ladies and gentlemen, post-AMI VSI is rare, but still remains a very high mortality. And this is a very and we need to give them prompt and proper management. And timing for surgery repair, there's the trend that the delayed surgery can offer a better survival outcome, but I agree with Dr. Ji. This is a kind of selection bias. And we can try our best to use different form or different combination of MCS, including balloon pump, including ECMO, in order to stabilize this group of patients before definite intervention or surgery repair. And this will probably offer a better survival outcome in this group of patients. And transcatheter closure is still an option in certain cases for sure. And probably if we have more evidence, and probably we will have some kind of different viewpoint that say probably in addition to MCS stabilize the patient, we can choose the transcatheter closure or transcatheter repair in order to reduce the shunting condition, to reduce the heart failure status, and proceed to the definite surgical repair. Thank you very much.
Thank you so much, Dr. Tsai, for your nice presentation. And my question is, do you think the timing of the surgery to repair the septal rupture is important? Because if patient remains stable, do you think we can do early or can wait for some time? Okay,
thank you very much. Yes, you are right. I think if we should try our best in order to stabilize the patient first. In my indexed case report, you see the end organ function stabilize gradually, so that we will have a better surgical outcome. But if we do the emergency surgery in the multiple organ failure status, you definitely with a very complexity condition, probably the patient will die soon after the surgery. And yeah, you are right. This is a kind of nature selection, right? We do the surgery for some stable patient, and we will have a better surgical outcome. Yes, so my point would be we should try our best to stabilize the patient, either with some MCS support in these advanced decompensated heart failure cases. And we should consider try probably transcatheter to reduce the shunt, at least from the big shunting to a minimal shunting. And by this kind of stabilization method, probably we can just take a break, take a deep breath, stabilize the patient, and proceed to the kind of elective surgery so that we will have a better outcome. So heart team approach is always, I think this is always a issue. Thank you.
I think so, because I think important issue for correct with the surgery is a difficult for decision and have to made by the heart team. Because the timing, I think, is important, maybe affect to the outcome of the patient. And we have some experience from Thailand about transcatheter closure by Dr. Kit. Do you share, Dr. Kit, maybe share some experience of transcatheter in Thailand or in your institute?
Yes, I'm still online.
Yeah, Professor Chi.
Yeah, I'm
Please.
still.
Oh, okay. So I think we, if Dr. Kit is not present at this time, please move to the next speaker. Okay, thank you.
Okay, thank you very much, President. And I'm very happy to introduce our last speaker, last but not the least, Dr. Tomoya Uchimuro from Japan. He is also a cardiosurgeon, and he's gonna deliver a great talk entitled with Acute Myocardial Infarction Complicated with Complex Left Ventricular Aneurysm Complications, Role of Surgical Ventricular Reconstruction. Tomoya Sensei, please.
Thank you for your kind introduction. Can you see?
Yes, very clearly. Proceed. Thank you.
Today, I'm going to talk about acute myocardial infarction, complicated with complex left ventricular aneurysm, role of surgical ventricular restoration. As you know, surgical ventricular restoration, SVR, is used as a procedure of choice for post-ischemic dilative cardiomyopathy to restore the left ventricular shape and volume in addition to CABG. I show the clinical outcome of our experience of SVR in the past 20 years. I would like to identify the SVR in current real-world clinical practice. Now I will tell you history of SVR. For the first time in history, Denton Cooley reported linear aneurysmectomy in 1959. The technique is still used as linear closure when the aneurysm is located. Next, Jaten, Dole, and Cooley reported end-ventricular patch repair in the 1980s. In 1996, Batista reported a partial left ventriculotomy. However, it is no longer a common technique today. In the 2000s, 3 techniques was reported from Japan: overlapping procedure by Dr. Masui, SAVE procedure by Dr. Isomura, and elite procedure by Dr. Yaku. However, in 2009, stitch trial was reported. After this, effort of SVR was tempered. The stitch trial revealed no difference in total mortality or cardiac hospitalization between patients randomly allocated to CABG versus CABG with SVR. Post-operative ESVI under 70 millimeter resulted in improved survival after CABG with SVR compared with CABG alone. In 2022 AHA guideline, SVR was only mentioned in the text, as shown in the slide. However, in European guideline, LV aneurysmectomy for patients with NYHA class 3 or 4, large thrombus in LV, arrhythmias due to aneurysm is recommended class 2A. SVR may be considered in selected patients in centers with expertise as class 2B. In Japan guideline, aneurysmectomy for giant LV thrombus or ventricular arrhythmia is class 1. Anterior wall SVR reducing LV SVI to 40 to 80 millimeter. For anterior OMI with low EF is class 2A. Posterior wall SVR is class 2B. We experienced 134 patients undergoing SVR between 2004 until 2023. Over those, about 80% underwent surgery before 2009. That was stitch trial was reported. Although the number of SVR has decreased, there are still definitely some indicated patients now. I will show you preoperative characteristics. Male gender was 82%, male age was 64 years old, mean ejection fraction was 35%. Operative procedure performed was shown. SAVE was performed in half of all patients. Linear closure was performed in 20%. Door and overlapping was performed in about 10%. Elite procedure and aneurysmectomy underwent about 5%. Concomitant surgery with SVR was as shown. CABG was performed in over 80%. Mitral valve repair or replacement was performed in over 40%. Papillary muscle procedures for tethering were performed in 20%. Perioperative outcomes were presented. Operative time was about 6 hours. Hospital mortality was 75%. Cause of hospital death were low output syndrome, heart failure in 8, myocardial infarction, and sepsis were 1 each. Echocardiographic data of LV volume were shown. LVDD, LVDS, EDVI, and ESVI reduced after surgery and were maintained 1 year later. LVEF had remained unchanged 1 year after surgery. Mitral valve regurgitation decreased postoperatively and were maintained 1 year later. Long-term outcomes were presented. All-over survival at 5 years was 73%, 53% at 10 years. Survival from cardiac death was 88% at 5 years and 65% at 10 years. Survival from rehospitalization for heart failure was 83% at 5 years and 71% at 10 years. I show the transition of procedures in the past 20 years. SAFE has remained mainstream procedure. Linear closure was the second similarly. The third was overlapping in about 2010. However, Elite replaced the third position in the past 10 years. Now I introduce SAVE procedure. First, left ventriculotomy as the center of my curve. And first, papillary muscle appropriation was performed. And marking the border between healthy and infarct myocardium. After cryoablation, hemashield patch was sutured to in the LV. Patch was sutured first to interventricular septum and trimming patch to approximate size. And patch was sutured transmurally as anterior to lateral wall. And the operative globe is used to ensure minimum LV volume. And trimming the patch to the appropriate size. And patch was fixed to anterior to lateral wall transmurally. And hemostasis of LV wall. And lastly, outer line of LV ventriculotomy was closed. And this is a safe procedure. The merit is to ensure the minimum LV volume by using hemashield patch. And the next elite procedure, I show the operative video. This procedure didn't use patch. First, papillary muscle approximation via elevectomy was performed, and Gore-Tex suture was placed in LV. After the LV repair, resuscitation of papillary muscle will be performed. And in this procedure, directly suture interluminal left ventricular wall was performed. The advantage of this procedure, a simple procedure, and postoperative elliptical shape after operation. However, the indication should be selected carefully. The postoperative LV volume may be reduced too much. In patients, those infarct area is circumferentially broad because the patch is not used. So, safe procedure is more performed in our institute. Finally, mitral annuloplasty ring was replaced and papillary muscle suspension to the anterior part of rigid ring and completed. Summary of our experience in the past 20 years. SVR brought significant reduction of LV volume and feasible long-term clinical outcomes. Safe procedure has advantage that both operative LV shape and volume can be adjusted by trimming of the patch. Therefore, it has been the most major SVR procedure. Next, I introduce SVR in current real-world clinical situation. In the past 5 years, LV thrombus was the most major indications of SVR. The second was aneurysmal rupture. SVR for heart failure control was only one patient. I will show one patient I experienced recently. A 60-year-old man with AMI was referred and transferred to our hospital. He had undergone emergent PCI to LAD, medical therapy for heart failure, low output syndrome, and ventricular arrhythmia, and performed one month after AMI onset, LV aneurysm and large thrombus were found on echocardiography. This is emergent coronary angiography. That culprit region of AMI was total occlusion of LAD, segment 6. And CT of right coronary and severe stenosis of circumflex artery were found too. And synergy stenting was implanted to the culprit region. And PCI was successfully performed. Echocardiography at 1 month after AMI onset was shown. Severe hypokinesis to akinesis in anterolateral, anteroseptal to inferior LV wall, and in apex, large thrombus formation was found. ESVI was 72 millimeter. And enhanced CT showed anteroseptal apex LV wall thickening and aneurysmal change and rich thrombus formation in LV cavity. Safe SVR and cryoablation and CABG leader to CX and SVG to RCA was performed successfully. he was discharged 50 days after surgery without any complication. And post-operative echocardiography and enhanced CT demonstrated that post-operative LV shape was elliptical and ESVI was reduced to 47 milliliter in the range recommended in the Japan guideline. And echocardiography at 1 year after surgery shows that elliptical LV shape and ESVI of reference zone. Indication of SVR in current real-world situation was presented. Recent progression of pharmacological treatment, device therapy by ICD and CRT replace the role of treatment for heart failure with low output syndrome. So therefore, realistic situation performing SVR are large or mobile thrombus formation in left ventriculum and left ventricular aneurysm formation. Finally, the conclusion. 134 patients undergoing SVR showed significant reduction of LV volume and feasible long-term clinical outcomes. Although the number of patients indicated for SVR has been decreasing, it remains a useful surgical technique. It is essential to select a procedure of various SVR based on the consideration of post-repair LV shape and volume. Thank you for your attention.
Thank you very much, Dr. Tomoya. A great talk. And I'm curious about, because I noticed that you routinely approximate the pulmonary muscle, right?
I see.
So how do you measure that? The distance, or you just how to measure the pulmonary muscle?
I also I usually use Teflon felt reinforced felt project reinforced 2O Teflon blade silk suture. Three pair of felt project reinforced blade silk suture.
Okay.
Was performed to papillary muscle approximation.
Yeah. Very good. Very good. And and after the reduction, every case you put a rigid ring, right?
Yeah.
For mitral valve.
Yeah.
Okay.
Yeah.
Okay.
In mitral valve repair for degenerative MR, we use partial ring. However, in ischemic MR, we use full ring, complete ring, because we perform papillary muscle subtension suture to penetrate the anterior part of the complete ring. So only in ischemic MR, we use complete full ring.
Okay, thank you. And in these patients with LV thrombus, do you usually use NOAC or Coumadin after the surgery? And how long?
We use Coumadin,
Warfarin, yeah.
Post-operatively. And
lifelong.
After for 3 to 6 months after operation, warfarin, and after there, DOAC is used.
Okay, thank you. Yeah. Any questions from the other attendant?
Dr. Tomoya? Dr. Tomoya?
Yeah.
May I ask you some question? How do you select the proper patient for this procedure, the ventricular reduction, surgical reduction for the pseudoaneurysm? How do you select the patient, the proper patient to this surgical procedure.
Do you mean how do I select the surgical procedure in SVR?
We will get the benefit from this procedure and the outcome in the long term in this patient.
Now I think the indication of SVR is only for if after MI thrombus formation was happened in patients or aneurysm formation was happened in patient. We use the SVR in operation. However, the patient is difficult to control heart failure because of low EF due to ischemic cardiomyopathy. The indication of SVR is poor, and in those cases, CRT is better to perform because SVR in very poor EF patients, the surgical results is not good from our experience.
Okay, thank you.
Thank you.
Do we have any question from some of our speaker? Okay, if it's no more question, I think today we learned a lot from our speaker. Mechanical complication after acute MI is uncommon, but very serious and challenging problem for our heart team practice. And the mortality in these patients still remain high. The understanding the current concept and treatment strategy is important. And today we learned a lot from our speaker. We have to thank all of our speaker, Dr. Ali, Dr. Shi, Dr. Kit, Dr. Tsai, and Dr. Tomoya, and also Dr. Chen, my chairperson, for this special session and for sharing important and knowledge today. And we hope to see you again in our next APSC Crowd Forum in cardiovascular disease. Thank you, and I will close this session. Thank you so much.
Thank you very much.
Thank you. See you.
Bye.
See you. Goodbye.
Thank you.